Hello to everyone in Singapore from Dublin. My name is David Robinson, and I'm delighted to be presenting on behalf of the LAMP team, our social prescribing project in St. James's Hospital. So I'll just start sharing my screen to present. So our social prescribing project is unique in Ireland in that it's based in a hospital. And I'm presenting on behalf of the team, myself, Dr. Gerard Boyle, medical physicist, and Bernie McGowan, our link worker. So just to signpost the talk, I'll give you a bit about the context first, and then the timeline of LAMP itself, and as a background, the timeline of social prescribing in Ireland. We have some convenient samples for baseline assessments and for before and after assessments as well, and then I'll touch on next steps. So just some context, I work in St. James's Hospital. It's the largest hospital on the island, and it's one of the oldest hospitals at 300 years, so it's secular and voluntary. It was a workhouse, and it was known as the Union at one point. It was also a foundling hospital at one point. If you had an unwanted baby, there was a turnstile at the front of the hospital. You could just drop your baby there. The turnstile would be turned around. The baby was taken in, and there were no questions asked. Within the hospital, I work in Mercer's Institute for Successful Aging. This was conceived as a one-stop shop for clinical research, teaching, and creative life as well. We have a creative life pillar. We have collaborations with the Irish Museum of Modern Art, with the National College of Art and Design, and we have artists in residence, as well as programs that patients and visitors can participate in. So as part of that, I'll explain some of my interest in social prescribing, and we decided we would set up a local social prescribing project based in the hospital, and we accept referrals from older persons clinics that we run, and also from the wards at point of discharge. There's a significant number of people with dementia in this age group, and many assessments over the course of the pandemic were performed in the individual's homes. I'll be touching on some of that during the talk. The timeline of LAMP, I was appointed as a consultant physician in 2011, and we went to visit Chicago, where there was a Southside Health and Vitality Studies project being run by the University of Chicago. Michelle Obama was backing it. And it was taking an asset-based approach to community development. So rather than concentrating on all the negatives, it was making a census or looking at all the positives within a community. And as foot of that, we began making community connections ourselves in 2012. St. James's is embedded in the community. It's very much part of it. It's a deprived inner city area. And we've had a long relationship with looking after the sick and the poor is the reason the hospital was founded. We emulated what they did in Chicago. We did a street census, a digital street census, when we enlisted local community organizations and local schools. We did this over a series of summers to collect data as part of a community mapping exercise. Now, the street census was probably overkill. We collected data on 6,000 assets in total, of which almost 600 were directly health or social care related. And we put those into an online searchable database that we used as a directory to help the link worker create prescriptions. So while this was happening, in the background, of course, social prescribing was taking off as a very much a ground up movement in the UK, and then also in Ireland. The first social prescribing project in Ireland was in the county of Donegal, in the far northwest of the country, which is quite an isolated rural county with long distances involved. I visited there as well, and we could see that there was a lot of synergy. We were thinking the same way, connecting people with different chronic conditions or in different social situations, addressing the social determinants of health and connecting them to community resources. I visited the University of Westminster in 2016, where at that point, Michael Dixon and Marie Polly were creating the social prescribing network of the UK. I just kind of default became the Irish representative by being the only person there. And coming home then with my co-chair, Tony Doherty, we created the All Ireland Social Prescribing Network. So I represent the South and the health sector, and Tony Doherty comes from the community and voluntary sector and represents the north of Ireland. We had our first All Ireland meeting hosted in Mesa in 2018, and we had subsequent meetings in the south of the country, and our most recent one was back in the north of the country in Derry. And these are attracting a lot of political attention. The most recent one had the health minister for the north of Ireland, and we had the health and well-being minister from the south of Ireland there. So social prescribing began to take off for us, though, in 2019. We'd been dealing with the Irish Health Service Executive for many years and not making much headway, because the thing about social prescribing is it links different sectors. It links the voluntary sector with the health sector. It links chronic disease with well-being. It's hard to fit it into a box. And I had conversations with people in the health service executive who said, well, what box does this fit into? And I made the point, it doesn't fit into a box, it connects the boxes, but that meant it was very difficult to get funding. So we bypassed the health service and went straight through the Dáil, which is the Irish Parliament, and presented ideas there. And it was taken up and it was written into the programme for government, which was a game changer. Then the health service executive took it on, and it's divided into different divisions, and health and well-being is the division that social prescribing sits in. And I think that's a good place for it, and it's conceptually it's a good place for looking for funding as well. There was a national framework written and also a framework for evaluation, and it's been rolled out across the country. There's now one link worker per 90,000 population, which would be about 50 or 60 link workers. While this was community-based, because of our involvement with it, we were considered maybe in a developmental or experimental site for other models of social prescribing. So we were awarded a link worker in St. James's Hospital. That person was appointed in May, and we set up referral pathways and referral reasons from our older persons clinics. We subspecialize in stroke, memory, falls, and bone health. And we have very busy local outpatients, as well as 4 inpatient wards. So in terms of results, and this is a convenient sample from the results that we've collated, which represents the first 16 months of the project. In May 2020, we started accepting referrals. You can see that there was quite a mix between medical team and other allied health professionals. Many of the referrals came from inpatient wards, just at the point of discharge as the person was going home. Others came from either our specialist clinics or our general outpatients. And we deal with older people. I mean, we're not age specific. I mean, you know, we deal with stroke in younger people or memory issues in younger people. But for the purpose of this program, we accepted people over the age of 65. So you can see it was quite a breadth. From my reading, about 40% of people in general social prescribing projects can be over the age of 65 anyway. So it's relevant to many social prescribing projects. This shows the effect of the lockdowns. To be honest, the whole thing is a blur, and I can't remember when Ireland went into lockdown and when it wasn't, but we had about 3 lockdowns over the course of the pandemic. Outpatient activity collapsed during that time, and inpatient activity was just purely COVID. We did continue the project in that time. At one point, our link worker was seconded onto the wards. This will give you an idea for the reasons for referral. Social isolation consisted of the bulk of it, or lack of social or cognitive stimulation. Less frequent reasons for referral were anxiety or mood, care or stress. There was a low number of unsuitable referrals, and I think that reflects just how embedded the link worker was in our unit. I should add, because of COVID and because of the demedicalization of the whole situation, our link worker didn't see people in clinics. She had her own office to see people, and she would often go out and do home visits during the pandemic as well, inappropriate PPE. She found that invaluable in terms of gathering information or getting to know the person. Significant number of people lived alone, 65%, 2/3. Another fifth quarter or thereabouts lived with a partner, and only 12% lived with a son or daughter. So obviously the pandemic exacerbated all of this. Because it's an older population, a significant number, 45% of our patients, there are patients, but they became participants when they're in the social prescribing project, carried a diagnosis of dementia or mild cognitive impairment. There are a number of specific programs in our community for people like that, and we have formal links with the Irish Museum of Modern Art, as I mentioned. And this will give you an idea of the range of different activities that people are linked into. Because a lot of this took place during the pandemic, some of the supports consisted of telephone support, e-packs, which were delivered to the individual's home to keep them cognitively or physically active. Bernie, our link worker, provided in-person support and activity packs for people as well. I mentioned the creative life pillar of MISA, and we have a number of music therapy workshops that take place inside our unit. Choirs on Zoom, traditional men's sheds. Alone is an organization that helps people living alone in Dublin, and there were people referred to that as well. And then reflecting the number of people with dementia, there were people referred to dementia supports as well. And then some more traditional referrals as well, in lower numbers, counselling services, Alcoholics Anonymous. So a very diverse group But loneliness, the theme throughout, social isolation, a theme throughout, exacerbated by the pandemic. Many of these people living alone, and their situations were difficult. Just to give you an idea of some of the baseline measurements, we used a couple of standard instruments. The MyCall, the Measure Your Self Concerns and Wellbeing, you're probably familiar with. So looking at concerns, two major concerns the person identifies and their overall well-being. So as I say, these are just convenience samples. We have to go through the entire data, but for 48 of the participants, the MyCall concern 1 average was 4.2, the same for for concern number 2, and the well-being score is 3.2. And this is just for 19, and the end changes between 19 and 17 depending on how complete the data is. But you can see that the level of concern goes down for both concern 1 and concern 2, and that was significantly different. And the well-being score also changed, and that was significantly different. And the WHO-5 well-being score increased, which reflects an improvement in a person's well-being. We also performed the WIM-WEBs, but that wasn't significant. We're continuing to collect and analyze this data. We have about 170 people through the program at this point. So, and we're pretty thorough at doing before and after scores. So we should have more information to add to this. There was a bit of learning in COVID. Obviously, we all went to virtual working, the usual supports for people were all shut down. So we had nothing to refer people to for some period. And this was substituted by activity packs and, where possible and appropriate, home visits to the person. As part of this, Bernie, our link worker, actually became the support worker, and that happened in a lot of social prescribing projects locally and across the country. And then one thing that came out was the idea of digital inequality. In order to be able to participate online, you need the skills and to use technology. You need to be able to afford that technology as well, and you need a decent internet connection. Our next steps, we've been awarded further funding, both from the government and also locally from the Mercer's Institute for Research and Aging, to expand the team. And we'll be able to hire a second link worker. We'll be interviewing for that in a few weeks. I'm hoping to expand into other clinics within the hospital. St. James's is a major national centre for HIV. We have about 3,500 people attending, which makes it the largest centre on the island. And we've other national specialties, such as we're a major cancer centre, and then the usual things like diabetes, COPD. I suppose it's an interesting way to take a disease-based approach to it, but I always think whereas health and well-being applies to everybody, but if you're a specific demographic, like an older person, or if you have a specific disease like obesity or HIV, you may have specific needs. So it's a nice way of tackling things, and it's also a nice way of testing the concept in different populations. And we're going to continue to collect and collate data. So in summary, hospital-based social prescribing is possible. I think we've demonstrated that, and the service is busy. It's probably busier than the community projects that I'm aware of. Our referred individuals, and we're dealing with an older population, have unique characteristics and needs, and we often have to refer them to specific supports. Our project was able to respond to the pandemic, thanks in no small part to the creativity and hard work of Bernie. And this type of social prescribing appears to have had a positive benefit to participants and based on subjective measures of well-being. I just want to acknowledge some of the funders of our projects, and thank you very much.